Hello, I hope you're having a good week. I'm Dr. John Cruz, and today I'm going to be talking about ADHD kills people. Um, I'm not trying to be provocative or inflammatory, but I am purposely countering two different narratives, both which have a kernel of truth in them, but I think need to be addressed head on. One is that ADHD is purely a positive condition, helping people be more creative, spontaneous, and that everyone with ADHD is brilliant in those regards and other regards. And two, that ADHD is a trivial condition, which ADHD does exist on a spectrum, but it certainly exists on a spectrum of from trivial to serious, and quite serious, in fact, in killing people. I'll get to in a minute. I'll be talking for about 20 minutes. If you have questions, I'm open to, you can write questions down as I'm talking. I will stick around for a minute or two at the end if you have your questions at the end, and if you want to post questions later, you're certainly welcome to do that then. Unfortunately, part of today I also will be reading, and I'm going to be reading this time from part of my book, and I'm going to be reading because I am talking about patient vignettes, and I want to be careful that I'm providing enough detail. I protected the patient's anonymity, but provided enough detail to make it hopefully vivid and exemplary description of the points I'm trying to make. But I don't want to spontaneously blurt out too much information that might reveal too much patient identification. So getting back to the main point, ADHD kills people. So one of the barriers to having ADHD treated seriously is many people think it's just an issue of distractibility and, oh, there's a squirrel. And it's sort of, ha ha ha, that's funny. People are doing silly things or messing up because they weren't listening all the time. But those messing ups can lead to very serious disruptions, again, of schooling, of education, work, social relationships, but it also kills people. And right now there's a movement in the mental health community among psychiatrists and others that we should be focusing on serious mental illnesses, which they usually identify as depression and bipolar disorder and schizophrenia, because those harm people and lead to a loss of functioning. And ADHD, I have never seen included in the lists when people are talking about this, and yet, as I'll see, I'll actually jump to it right now, ADHD kills people. So a couple of studies have shown you are about twice as likely to have a premature death if you have ADHD compared to the general population. About half of those excess deaths are due to accidents, and that means that both people who have inattentive forms of ADHD, so who are not paying attention or missing vital information, that can contribute to accidents and death, and also impulsivity can contribute. If you switch lanes too suddenly in traffic, if you run across the street without looking both ways, if you are doing a dangerous job without making sure your precautionary measures are in place, you're likely to die, and that's a death attributable to ADHD. So ADHD also seems to increase deaths from suicide, increases deaths from murder, and even deaths from medical conditions seem to be somewhat higher with ADHD. The conjecture there is that if you're less able to stay on track with following your medications or following follow-up procedures that are needed for your condition, then you are more likely to run into serious implications, including dying from your condition. So the few studies that have been published suggest that life expectancy is reduced about 10 years in people with ADHD. And again, comparing it to the serious mental illnesses, studies of depression, I pulled up the first four I could find, or three. Depression in adults decreased life expectancy 5 years in one, 8 years in another, 10 years in another, all comparable or even less than what ADHD does. Part of that is that ADHD is affecting people at even younger ages on average, certainly, than in depression. And mortality rates are higher among kids than among adults. And again, a lot of it is accidents, trauma, things like that. And ADHD increases the risk for that. We know that ADHD increases your risk for car accidents, doubling it 2 or 3 times higher than the basic rate for whatever your age or gender as a driver. And the good aspect to that is that we also have studies showing people who are medicated specifically with stimulant medications brings down the car accident rate to the background rate for that person's gender and age. I mentioned that ADHD increases the risk for suicidality, and that's thought to be because of the increased impulsivity. A significant factor for completed suicidality or suicides is an impulsivity factor. So I'm not saying ADHD alone is driving the suicide, but ADHD in combination with depression. Many people with depression have suicidal feelings, but you are more likely to act on it with ADHD in the picture. And the rate of dying from a homicide is higher with ADHD, probably because you're less vigilant about your surroundings or more impulsive about putting yourself in more dangerous conditions. So those are all ways that ADHD can impact your own life or cut it short. I will also be talking in future episodes how ADHD can impact, and seriously enough to the point of death, in the lives of others. So again, when we talked about car accidents, those include fatal and lethal accidents, and those are accidents that are not always or only single car, single driver incidents. So people with ADHD do wind up killing others through car accidents. Part of the reason why you're not allowed to be licensed as a pilot in this country and most others with ADHD is because awareness of impulsivity or inattention in a job like that could lead to killing or harming other people. And also admission to the military in this country. Actually, ADHD itself is not a disqualifying condition, but treatment for ADHD with stimulants is, which is kind of almost backwards. That you can have the condition, but if you're bothering to treat it effectively, then you can't be in the military. And another irony piled on top of that one, to be President of the United States, which means you are Commander-in-Chief of the military forces. You don't even have to be screened for your ADHD. And yet I would argue that Donald Trump is a wonderful example of how having ADHD can wind up killing other people. So one of my future talks will be on how his ADHD contributed largely to his response or lack of response to the COVID epidemic, which has resulted in killing people. So those are some of the statistics. Why I'm going into the anecdotes is because the people who attack the diagnosis of ADHD or the medications with ADHD, they cite numbers and statistics too, but more often they rely on anecdotes where they make a big to-do about a certain story of a young person who's been misdiagnosed by their claim or mistreated or overprescribed, and that led to horrible, tragic, miserable deaths and destruction. And again, there's absolutely a kernel of truth in that. There certainly are people who have been diagnosed with the condition who don't have it, who have been mistreated, who have been improperly followed or treated, and that can lead to death and destruction. But to make my point, in addition to citing the statistics, I am going to go into some anecdotes to make it vividly clear how ADHD can kill people and destroy lives. And again, I have 3 different anecdotes. One is not in the book, and I'm going to start with that. So I'm going to talk, and again, I'm going to be reading from the book so I don't inadvertently reveal too much information. All the names have been changed to protect people's anonymity. So the first person I'm going to be talking about is Matt. He's a 40-year-old in his 40s. I started working with him a few years ago. He had not been diagnosed with ADHD up until then. Highly intelligent, has a PhD in a science-related field and successful in his career, which is tech industry. And when he learned and discovered some of his impulsivity, some of his inattentiveness were coming from ADHD, and learned about the strong genetic component to it, it opened his eyes to how many family members he had with ADHD. Horribly and tragically, just this past month, Matt's 70-year-old father was doing repair work on the roof of the house, fell off, died as a result of his brain trauma, which was horrible, and horribleness was compounded by COVID, so Matt was unable to, see his father in the hospital before he actually succumbed from his injuries, could not be there in person for his family. And yet, in a strange way, he explained how the ADHD gave him solace. And it gave him solace because part of what he did in the situation was say, oh my God, if I had been there, I could have been fixing the roof, or I would have probably insisted on getting professional help for doing the roof. Somehow I could have intervened and led to a different outcome. But when he thought about it and realized that his father had done, yes, was a skilled manual laborer and good with his hands and good at fixing things, but had had many other near-death experiences from not paying attention. And it wasn't just Matt's dad, but he had several uncles, grandparents, related extended family members, because ADHD is strongly genetically there's a strong genetic influence on ADHD. There was sort of a cursed family scenario going on where numbers of people in this family had died from tragic, bizarre, violent accidents, and it helped him put the perspective, this isn't just a cursed family, unless ADHD you see as a curse, but there were specific aspects of their impulsivity, of their poor decision making, of their inattentiveness to all the details of the situation, which were direct contributors to all these random accidents. And that provided some sense of understanding and also helped assuage his guilt that he could have been there to prevent any episode of that nature. So I'm going to move on to two other tragic situations, and again, I'm going to be reading from my book. So the first one I'm going to talk about is Paul. So Paul was the son of one of my patients. Concerns about his mental health arose at age 12 when he hit his mother over the head with a skateboard during an argument, and both of them were taken to the emergency room. Because of gross administrative inadequacies, his managed care mental health system didn't bother to schedule his first follow-up with a social worker until a full 6 weeks after the ER visit. So there's a guy coming in, or young man, 12-year-old boy, with the mother. There's no follow-up in the system for a whole 6 weeks. A child psychiatrist did not see him until another month after the social worker had evaluated him. And at this first in-depth evaluation with the psychiatrist, 75 days after the initial crisis, the doctor determined that Paul had ADHD. However, since the doctor was about to depart on a lengthy vacation, no treatment was initiated for yet another 2 months. All the data in here is exactly verbatim what happened, not exaggerating. The intermittent, delayed, and partial treatment served to convey to Paul and his family that his ADHD was not important enough to address. Over the next several years, Paul almost failed out of school, started using street drugs, and began a life of petty crime. He was only on ADHD medication for brief periods during which his school performance would improve. He would communicate much more effectively with family members, and he would stop using both meth and marijuana. Many factors contributed to the fragmented and inadequate treatment of his ADHD, including the managed care company's trivialization of mental health, the disorganization in Paul's family household, and his own ADHD. And his own ADHD contributed to his missing appointments, inconsistencies in filling and taking medication, and decreasing Paul's awareness of how his behavior alienated others and led to poor decision-making. Paul was in and out of jail during his 20s for selling drugs, fencing stolen goods, and petty scams. One afternoon, he returned to his car in a shopping mall parking lot, unaware that he had been staked out by police because it was a stolen vehicle he was driving. He did know that he had several outstanding warrants for his arrest because of minor parole violations. When a uniformed cops approached the car right after Paul got in it, he impulsively slammed the car into reverse, even though there was no open avenue in this crowded parking lot for escape. His car hit one of the officers, and then Paul died in the ensuing fusillade of police bullets. His untreated ADHD contributed to the impulsive reaction that triggered the immediate cause of his death, and his ADHD also contributed to the many rash decisions that had propelled him along the path that ended in that parking lot. And I would argue that extrapolating from Paul's positive experiences on prescription stimulants, it's likely that if he had stayed on his medications, he would be alive today, and that if he had been accurately and quickly treated and treated as if ADHD was a serious and life-threatening condition, it probably would not have taken his life. That's conjecture, but that's the argument I'm making. So the third person I'm going to talk about is Lucy. I first evaluated Lucy for admission to an outpatient medication group connected with a psychotherapy clinic after several months of talk therapy had not allayed her depression and anxiety. Her speech was loud and rapid, cartwheeling from topic to topic, often veering into subjects that brought up in her strong feelings of anger, sadness, frustration, and disgust. She had been fired from several jobs for missing deadlines, disagreeing vociferously with colleagues, and poor attention to details, despite otherwise being perceived as hardworking, intelligent, and energetic. At the end of the evaluation I had with her, I suggested that her distractibility, inattention, and emotional volatility all could be part of ADHD. But she had adamantly rejected the diagnosis and denied that any of these symptoms had been present in her childhood. It was not until the fourth group session, when several group members commented on her ADHD symptoms, that she conceded that she had been treated with Ritalin for ADHD in her childhood, but had felt so coerced and so stigmatized by the treatment that she did not want to repeat any aspect of it. Her group experience, however, helped show that even if she wanted to ignore or to try to hide her ADHD symptoms, it wasn't working. They were causing difficulties in her interactions with others, both in the group and in the rest of her life. She decided that it made sense to make another attempt at directly treating her ADHD with medications. We tried non-stimulant medications that partially helped with her ADHD and her mood and anxiety symptoms. We also used cognitive behavioral therapy techniques adapted for ADHD. Over the course of 2 years, she was able to find a job that was a much better match for her interests and to strengthen several friendships. In the medication group, she was calmer, more able to appropriately wait her turn to speak, and more adept at modulating her emotions. That sounds pretty good. Lucy moved out of state, stopped her medications, and was unable to replicate much of the structure and social support that had helped her stay on track. Years later, feeling defeated by the simultaneously termination of another job and of a romantic relationship, she flew back to San Francisco without any plan other than going to the emergency room. She was hospitalized because of her suicidal thoughts. The psychiatric inpatient staff informed me of the hospitalization and that they were treating her for mania. I repeatedly described to the staff that Lucy had displayed this pattern of rapid, scattered speech, volatile emotions, distractibility at every one of my sessions with her across a decade, and that her family, teachers, and coworkers corroborated that she presented this way on a daily basis for more than 40 years. Furthermore, in the hospital, she was not speaking in ways that were grandiose or silly or delusional. She was sleeping for 6 hours or more each night and was not acting in ways that were bizarre or particularly impulsive. I explained that Lucy had ongoing severe ADHD, exacerbated now by this recent life crisis, and that she was not in the midst of a manic episode. Nevertheless, they sedated her with increasing doses of a potent antipsychotic medication in an attempt to, quote, stabilize her mood, unquote. They repeated that her speech did slow down. They reported that her speech did slow down to the point of being slurred, and her emotions flattened out during her stay, but also that she remained, quote, unquote, oppositional, unquote, to their treatment plan, and, quote, defiant, unquote, in her insistence that they address her ADHD, all of which they took as further confirmation of her mania, which she never had. After a few days of overwhelming sedation, the hospital discharged her. Within a day, still despairing and feeling profoundly misunderstood, She jumped off the Golden Gate Bridge. For Lucy, identifying and treating her ADHD had provided only partial relief during her life, but the failure to identify ADHD in her final weeks killed her. So that's a tragic and sad note, but I think we do need to use anecdotes to explain, in addition to the statistics, that ADHD is a potentially serious condition. That does not mean everyone with it's going to die from horrible accidents or suicide. It does not mean that everyone has concomitant depression with it, but it means this is not just a trivial condition. This is not just an innocuous condition. This is not just a positive condition. So that anecdotes from my book, Recognizing Adult ADHD. Hopefully some of my subsequent talks will be more at least uplifting or positive. And again, the positive framing of this is if we identify it, we can treat it. The whole point of making a diagnosis in mental health or in the rest of medicine is threefold. One, so we can understand what's going on. Two, so we would know how things are likely to unfold if we don't intervene. And three, what would be appropriate interventions or treatments that are specifically tailored to that individual with that specific condition. So I am open to questions if anyone has questions. I'll stick around for maybe a minute. Again, you can comment later if you want to comment. Next week's talk will be on understanding ADD as an executive function disorder. So last week I went through the 18 DSM-5 criteria for ADHD, which only capture a narrow range of impulsive, hyperactive, and inattentive symptoms, and there is more to ADHD. ADHD is an executive function disorder, problem of executive function disorders, which is why it's ironic that we have chosen as chief executive someone with an executive function disorder. So more on that next week. Take care of yourself, be safe, be healthy, and I will be back next Friday at 11. That's all. Bye.